Thank you, Melissa. Good morning, everybody. Unfortunately, I missed trivia last night. My plane landed a heck of a lot later than anyone expected. I hope everybody had a terrific time. I want to welcome everyone from all over the world. I also want to apologize for starting a lot later than we wanted to this morning. Just some technical issues that we were running through. So we do apologize. I want to thank those of you who are staying up late to join us, those of you who woke up at an ungodly hour just to join us. I remember doing this conference virtually for the first time last year, not knowing, having any idea how it would be received or if anyone would even be watching. Amazingly enough, we had one of our largest conference turnouts ever, most of them first timers, and that trend has continued through now. So thank you for your input, your feedback. We've catered a lot of our programs this year and our accessibility to how you want to receive information, how you want to interact with the foundation and with each other. And we couldn't be happier. Moving forward, our goal is to continue providing programs and information, especially like our translations today. Information, how you want them, when you need them. So please keep the comments coming. Let us know how you feel about what we're doing, what you want us to do differently, what you'd like us to add. Speaking of comments, if you're not familiar with the chat function down there at the bottom, click on it, talk to each other, ask questions. We'll have some time at the close of this session to answer as many questions as we possibly can. You can ask anything of me, Tracy, the amazing medical professionals coming your way in just a few minutes. So click and type away, talk to each other, say hi. There are folks from all different countries here. So use it. We'll be answering and talking to you as well throughout the session. Before we meet our incredible docs, I want to thank the incredible and resilient OIF staff for keeping all of this afloat the past 16, 17 months and pulling together all the town halls, the virtual sessions, and most importantly, the virtual fundraising. That is what kept us afloat. Melissa Bernardi and her team have shifted completely from what we've always done and opened so many new doors. And it's just been an amazing process, and to see everybody involved in ways that we never thought possible. And what an amazing sign that some of the fundraisers will be held in person this summer, including Ken Gudek and Jim Early's New Hampshire Classic, Riley's Gathering Place, hi Tony Benish, and the Miracle Michael outing that's been going on for over 2 decades now. So also want to extend a huge thanks to all of our board members. Many of them are on this call with us this morning. They've been tireless in helping Tracy navigate this completely unexpected year. And last but not least, as you see on the screen, our very, very generous group of sponsors. Be on the lookout for their videos playing throughout the weekend. And you'll see them taking part as well in some of our breakout sessions. So let's get down to the good stuff. I don't want to waste any more time. First up, Dr. Laura Tosi. She's the director of the bone health at Children's National. I've had the pleasure, absolute pleasure of serving on the board with Laura for 7 years. I think it's been 7 years now. It doesn't seem like it. And just being around her, my IQ has increased at least 10 points. So she has been unwavering in her support and dedication to the OI community. For the very latest in our patient-centered outcomes research study and our COVID survey, I'm going to turn it over to Dr. Tosi.
Thanks so much, Cameron. I'm never good at technology, but with a little luck, we're going to be okay. Maybe. Back. Nope. I can go backwards. Maybe. No, I can't. There we go. All righty. So it's very exciting for me to be your kickoff speaker today and to talk about something that's very near and dear to my heart, our patient-centered outcomes research project. This has been a magic time for us. Some of you may have seen a couple of these slides last year, but for those of you who are new, let me bring you up to date. And for those of you who don't know me, let me just take the liberty of making a couple of personal comments. I am a pediatric orthopedic surgeon in Washington, D.C. I've been here many more years than I want to admit in a public place. But what that's meant is that I have had an extraordinary opportunity to witness the evolving story of osteogenesis imperfecta. And as a surgeon, have absolutely seen the improvement of outcomes with bisphosphonates, rotting, but I've also shared your pulmonary concerns and the desire for new and better medications. Because I've been here so long, not only am I a grandmother many times over for many of my patients, but I have faced what many people are facing, which is that the American healthcare system is not ready for adults who have any kind of issues that aren't the standard diabetes and heart attack. And so the issue that has come up over and over again, and many of you have participated already in some of my surveys, is how do we develop a strategy that will capture this rapidly changing story, not just for today, but for the long term. So I've been torturing poor Tracy about this for a long time. And most luckily, we discovered the Patient-Centered Outcomes Research Institute in DC. And we applied for a grant. And in fact, we're awarded one, started in June of 2019. And we just finished our final report a couple of weeks ago. That doesn't mean we're done, but it does mean we have new directions. The key thing about patient-centered outcomes research is a priority change. In the past, the medical profession has generally set priorities, has decided what we're going to measure, et cetera. And the important thing about patient-centered outcomes research is it's a two-way street, and it depends tremendously on patient engagement. And it's based on the fundamental belief that if you're going to provide the best care and information, the OI community needs to be driving the science. And not only do they need to come up with ideas, but they need to be active participants throughout the entire research process. So we started out with a certain plan, excuse me, and we started just as we had promised our funders that we would start reaching out, and Tracy and I and other people on this call were going to regional meetings, et cetera, talking about the importance of patient-centered outcomes research. We were holding early sessions on training people in what we call PCOR, patient-centered outcomes research. PCOR, it's much easier to say PCOR. When bango, COVID-19 hit. And, you know, so many of us have to say, so where were we? And for me personally, the pandemic was announced just as I arrived in Phoenix to participate in an OI regional meeting. And I opened up my email and there was this mandate, don't leave. And if you leave, you can't come back. A story about COVID. I'm sure many of you remember where you were that weekend in March. And so all of our plans sort of went up in smoke really quite rapidly. We had to rethink everything. One of the things we did too was apply for a PCORI COVID supplement, which happily we won. Now, luckily, we were way ahead, thanks to Tracy, on many of our abilities, is the way I would call it. We had been already doing significant virtual meetings because, as I hope you are aware, the OI Foundation supports both a monthly Zoom rare bone disease educational program and a monthly OI educational program. So the team at the foundation was tremendously facile dealing with that Zoom. I think the guy who invented Zoom needs a Nobel Prize. Nothing else works as well, for me at least, as Zoom. It's very simple. But we right away, so first weekend in March, they declare the pandemic. The first weekend in April, maybe a couple of days after, was when we were supposed to have our first big educational session. Not only did we have it, but we were able to house almost 4 times as many people as we originally planned on, because we didn't have to pay for transportation. Nobody could have a hotel room. So we were there. And our big finding right off the bat was we could sing Kumbaya better. We could really engage far more people. And ironically, for everyone, and I'm biased, particularly professionals, there was less time away at a time when delivering care was so very critical. Tracy leapt to the fore, and I think it's important to recognize how on a dime, really, she turned around the community calls that were so very supportive to the OI community. And this is just a list of the calls that were created. Not that she did them on themselves, but in fact, we were aided by a small army of patients, caregivers, clinicians, and researcher volunteers. Everybody stepped up. Ultimately, that allowed for the creation of what we call the COVID-19 toolbox, which will be an enduring legacy on the OI Foundation website. Because what typically happens is you give a talk, you give a seminar, and it disappears into the ether, never to be seen again. The beauty of Zoom, once again, is we were able to record things so that the people who couldn't participate could simply check in later. And we've been thrilled by the number of folks who have decided to do just that. I think most of you are aware that the foundation has the OI registry, and we leverage that to start tracking evolving issues dealing with COVID. And this also was an opportunity for us, because the complaint we hear over and over again is, well, I helped out with this or that research project and I never found out what happened. And the nice thing was, since Breakthrough is online, we could get our results out quickly. Just, I'll take a moment to speak to some of the recent concerns. So we finished up our last survey at the end of March, and we were very interested to find 88 people who believed that they had had COVID. And of those, half had been diagnosed by a doctor. So it wasn't just that they'd had a bad day. What was concerning to us is, of those who had had COVID, 44 or 50% reported at least one long COVID symptom lasting longer than 4 weeks after infection. That's much higher than the national rate. So please be on the lookout. Our next COVID survey is heading your way. We really want to follow up on this and know what's going on, so that we can, again, share it with the community, keep everyone up to date. One of our big concerns that the foundation's really been working on, and I care a lot about as an orthopedic surgeon, is that over 50% of folks reported that they were less active. That's really important. Bone requires impact loading. Bone requires activity. And so speaking out about the importance to stay active and exercise as frequently as possible has become one of our mantras. Now, the reality is we faced a number of challenges, and there are a bunch that we're still grappling with. One of the things I would ask you to watch out for is our next postcard, because we are eager to try to understand how significant the digital divide is. Is this something we need to watch out for? Certainly all of the issues with keeping our kids in school, keeping the kids on the internet, brought attention to that for the school age child, but what about the rest of the US community? And how important is that to OI? We also had to face up to the fact that we weren't nearly as diverse as we should be. If you come to my clinic, I assure you, we look like America. But in fact, the respondents for our questionnaires don't. It has mostly been, and we thank you, white women, but we need to know more about how the entire community feels about every issue. And Tracy will be speaking at length about this at another time. Another quite embarrassing, almost, thing was that while the OI Foundation has had a long and wonderful relationship with many scientists and many clinics, in fact, it wasn't even half of the folks who call themselves OI clinics in America. And we had to face up to the fact that if we are really going to give good care everywhere, if we're going to democratize healthcare, one of my most favorite phrases, we have to be sure that all of the clinics have the same information and are coming up to speed. And we have been working very hard on that. Yet another challenge we're still grappling with. What tools work best when it comes to reaching out to you? When we sent out our first survey, we used our OI registry, which is really great because we can do shorter questionnaires because everyone's filled out a short thing called information about you. But we didn't even get 200 respondents. Second time around, and I'm not sure it's because everybody loved our breakthrough article or we made it easier, we used SurveyMonkey, we got almost 650 respondents. We are eager to know what the community, what tools the community wants to use so that we do a better job grabbing everyone's opinions. And again, a little paid political announcement here. Please watch out for COVID survey number 3, and also watch out for the additional surveys that are going to be coming your way. Dr. Krakow is particularly working on postpartum hemorrhage, which is so important to so many of our women. So looking ahead, where are we? I hope the way you'll look at this is that what we're trying to get a handle on is what do the next 50 or more years look like? And we need everyone to understand there won't be immediate answers. So that this is just like your 401k. It's an investment, but with luck, it's going to improve the quality of care we provide for everyone. So the award may have ended, but not our commitment. Things that are right at the tip of our activity list. How do we ensure that we are supporting all members of the OI community? How do we address diversity? How do we address access? How do we engage more community members to help us define this rapidly changing disorder? COVID isn't going away. What kinds of questions should we ask you next? And what kinds of presentations should we bring to you so everyone feels the safest possible? And the thing that is very important to me, how do we expand access to quality care for adults? It takes a village, and I cannot begin to tell you how many dozens of community members, clinicians, researchers participated, but I want to say a particular thank you to Mark Birdwessel, who led our PCORI advisory board, Michelle Dupre, who led our education committee, and Cameron, who led our communications. Tracy It has just been the best partner ever. And Bryce Reeve is the person who keeps us doing this academically correct from Duke. We really appreciate him. So in conclusion, what's our ask? Our ask is that you please consider working with us, read about what we're doing in Breakthrough and our website, participate in PCOR training and research, sign up for the OI patient registry, participate in our surveys and focus groups, and tell us what you want to know so that we really are responding, that this really is patient-centered. Everyone's voice matters, everywhere, every day. People with OI, parents, family members, clinicians and researchers. We all have a stake in this, and we look forward to working with everyone. And on that note, I'll say thank you.
Laura, I appreciate the thanks, and it has been an absolute pleasure working on this project with you. But for those of us, Tracy, myself, and a bunch of other folks who have gotten those 2 a.m. emails from Laura, you know how hard she's working on this. As I mentioned before, absolutely tireless and unwavering. And there are 2 other folks that I want to mention that are the unsung heroes on this. They're on Dr. Tosi's team. Austin and Elmer, you guys are absolutely amazing. The work you've put into this, cannot thank you enough for that. So for those of you who have not registered for the OI registry, please, we pushed this last year. We're going to push it again this year. We're going to keep pushing it because that is the information that gives us the wherewithal to direct research, to direct programs, to direct funding. So we'll have it. There it is right there on the chat. If you haven't clicked on the chat yet, it is right there. Would love to have as many, especially guys. We have a ton of women in the OI registry. Guys, we need you as fathers, as patients, as brothers, as sons. We really, really need your participation in this. So I do want to thank you for that. Earlier, I mentioned all the folks that got up early that are staying up late. We now have Ireland, Germany, the Netherlands, Egypt, Quebec, Ecuador, Gambia, West Africa, Norway, Latvia, Venezuela, Honolulu, and all across the US. So thank you for joining us. Talk to each other on the chat, make some friends. This is how we connect. So cannot thank you guys enough for joining us, and we'll keep this going. Up next, the person who deserves probably the bulk of the credit for helping us navigate the initial stages of COVID. Dr. Sandy Sandhaus is a professor of medicine at National Jewish Health in Denver. Since 2001, he's been the medical director for AlphaNet and the Alpha One Foundation. He's also board certified in internal medicine and pulmonary disease. He's a former OIF board member, and I would like to welcome Dr. Sandhaus.
Thanks very much. Tough act to follow, speaking after Laura. And I'm a one-trick pony. I'm mostly concentrating on pulmonary and cardiopulmonary issues. And I'm going to review what we've learned in research on lung problems in OI and where we're going. Anyone who's heard me speak before about this will recognize some of these issues, and I'm going to try to put them into context in a historical sense as we move forward through this research presentation. First of all, as I always start out, the majority of individuals who die with OI have been found to die of respiratory complications or respiratory issues. Respiratory failure is the leading cause of death in patients with OI. Research has shown some relationship between scoliosis and a reduction in vital capacity of the lungs. And we'll be talking about vital capacity quite a bit. It's also called FVC. That's how much you can blow out if you've taken a deep breath in and blast all your air out, and we measure that quantity. When vital capacity is low, we usually call that restrictive lung disease, that you're not able to have the same lung capacity as someone whose lung function isn't restricted. But restrictive lung disease in OI patients with no scoliosis or with mild spinal curves suggests that there might be abnormalities in the lungs themselves of OI patients, whereas most people assumed before that understanding that all of the issues in OI were due to abnormalities of the chest wall, scoliosis, rib fractures, vertebral fractures, things like that. So pulmonary issues often dominate the final years of an OI patient's life. Our understanding is not as mature about lung disease in OI as other issues facing OI patients. And individuals with OI can have respiratory issues that everyone has, such as chronic obstructive pulmonary disease, asthma, things like that, that are made worse by the fact that they have OI. And there are also a whole group of upper airway issues that are associated with OI that have to do with tortuosity of the trachea and things like that that are due to short stature and things along those lines. So there's an array of aspects to pulmonary issues in OI. We did start out when we decided to evaluate lung problems in OI in more detail with what we call a retrospective study. This was done with patients who were seen at the Hospital for Special Surgery. We went back and looked at the charts of patients who had had measurements of their scoliosis and their lung function done over the years. And you could see the people who participated in this work, which has been published now. And I'm going to summarize all the work in this one table. It may be difficult to see that there are dots scattered all over this graphic, and that the left-hand vertical column represents the curve of the spine, how much scoliosis there is, and the bottom is a measure of how much lung restriction there is. But it doesn't matter whether you understand those things or not. You can see that those dots are scattered all over this graphic. And in fact, statistically, there isn't a statistically significant correlation between the severity of the scoliosis and the amount of pulmonary restriction there is, even though that's been assumed for many years to be the main, the scoliosis has been assumed to be the main contributor to lung disease in OI. So in conclusion, that study found that pulmonary dysfunction, defined as these values I talked about, the how much you can blow out in 1 second, which is the FEV1, and how much you can blow out in total, the forced vital capacity, is not statistically significantly correlated with the severity of scoliosis. And this supports the hypothesis that decreased lung function in OI is actually a function of the OI itself, rather than being entirely related to the amount of deformity of the chest cavity that there is. So with that, we decided to do a prospective study as opposed to retrospective. In other words, we would enroll patients and measure them looking forward to see if we could confirm and identify issues with OI. And this pilot study initially targeted enrollment of under 30 patients. I'm going to report one of the early reports that we did on this when we only had about 14 patients enrolled. We're now up to over 40. And this is continuing to enroll, and it enrolls patients and does extensive studies on their lung function, on their heart function, on their spinal curves, on all kinds of aspects of their anatomy that might affect their lung function and heart function. And concentrating again on the lungs, I'm talking about what we learned about the lungs. So we wanted to define parameters that were meaningful for measuring people's lung function into the future, explore cardiac and respiratory issues, the presence and type of scoliosis, the type of OI. We also measured through questionnaires what the quality of life was, both overall and pulmonary quality of life, and assess the relationship between severity of scoliosis, pulmonary function, in a prospective and longitudinal fashion. In other words, looking forward and looking at repeated measures over time. So our hypothesis was that the reduced pulmonary function is intrinsic to osteogenesis imperfecta and not exclusively related to scoliosis or abnormal chest wall architecture. What did we find in our initial patients? And I will say that the results that we obtained and that I'm presenting here have been confirmed as we've enrolled more and more OI patients in this study. We did have about a third of the patients joined the study and already had pulmonary issues that they had identified. In this case, when we had 14 patients, 2 already had a diagnosis of sleep apnea and 2 already had a diagnosis of asthma. 14% of the people who had enrolled at that time were smokers. None had diabetes. We had a wide variety of spine curvatures, but you can see there were many of the spine curvatures were severe. The average scoliosis was 57% or 57 degrees, I think is what that means. Or at least 57% had scoliosis. And then you can see the percentage that had it in different locations. In the chest area, in the lower chest area, you can see the average curve was actually 48 degrees. And none in the initial patients had scoliosis surgery. That's not the case anymore. In terms of pulmonary function, we found that there was restrictive physiology. In other words, the lung function tests suggested there was restriction to air movement and air capacity in 71% of the patients that enrolled. The average maximum voluntary ventilation, the amount of air that someone can breathe in and out as quickly as they can over 1 minute, was remarkably good considering the degree of restriction. The results were evaluated based on comparison to a percent predicted value. Now, percent predicted values in lung function testing are based on 4 parameters: age, sex, race, and height. And so when you have people who have short stature, there's no validated standard for measuring pulmonary function in people with OI. That's why we chose a relative value, the ratio of FEV1 to FVC, as the way of measuring restriction. We also did chest CTs on everyone who enrolled in this study. And the most interesting result of the entire study was our chest CT results. We found several, relatively benign abnormalities, but almost everyone who had a chest CT in this study showed thickening of the bronchial walls without any explanation for that thickening of the bronchial walls. And we're still exploring why that might be. We also, as I mentioned, looked at quality of life, and we found that the SF-36, which is a measure of general quality of life, had scores that showed worse quality of life than the general population. We also had a significant number of people who have scores indicating poor sleep quality, and then a specific measure of lung-related quality of life showed worse results, and in other words, greater limitation than the general population. So our conclusions from this pilot study, and they remain true today, is that respiratory insufficiency may be intrinsic to OI lungs and not entirely due to abnormalities of the chest wall and spine. Worst pulmonary function in patients with OI leads to poorer quality of life. The study has currently, as I mentioned, enrolled over 40 subjects to date. There are bronchial wall abnormalities that appear to be unique to OI, and that's where we're heading next. And we thank the OI Foundation for the generous funding for this study. And I have no idea where those orange lines came from. The Hospital for Special Surgery study, as I mentioned, continues and expands. We're expanding this study to continue enrollment to add bronchoscopic lung biopsy to a small group of people who agree to have this done. Basically, we put a tube into the lungs of people who agree to participate in this, and we take grain of rice size biopsies from the bronchial walls and the alveoli of patients that are fortunately put into a twilight sleep. And once again, this addition to the study is being funded by the generosity of the people who donate to the Alpha One Foundation. Excuse me, the OI Foundation. There I get my foundations confused. Additional sites are planned to increase the reach and power of the study, and this is thanks to potential funding from the Brittle Bone Disease Consortium. That's where we stand with the studies that are ongoing and beginning. But I have to mention, since I tend to be the face of pulmonary research in OI, that this is a team effort led very capably by Kathleen Raggio at the Hospital for Special Surgery in New York. The force behind the throne is Holly Laturco, Erin Carter, G.D. Chetna, all at the Hospital for Special Surgery. Then Nancy Pleshko at Temple University. Sharad Fadina is the bronchoscopist at Columbia University who'll be doing the biopsies on our patients. Mohammed Chowdhury is in the pathology department there. Sergey Lykin is going to do gene expression on the biopsies, and he's based at the National Institutes of Health. And Roy Morello has developed animal models of lung disease that we're trying our techniques on first at the University of Alabama. And finally, I'm kind of the face of this, working in Denver, Colorado. There are a large number of studies going on in animal models of OI evaluating various medications that may someday be used to treat OI in humans, and some of these may have a beneficial effect on the lung disease. And my final comment, if you haven't received your COVID-19 vaccine yet, please get it. Thank you very much.
Thank you, Dr. Sandhaus. And for those of you who have access to the OIF website, oif.org/information center, we have a ton of medically verified and regularly updated information on there. There's respiratory fact sheets on there, a number of different issues that are on there. So if you want to easy access to this information, you can go right on there and it'll get you there. You can download them, you can read them on the website, but they are all there, they're updated and they're verified. So moving on, Dr. Brendan Lee is a familiar face around these parts. And since both of us are in Texas, I can say that. He is a pediatrician, he's a geneticist, he's the department chair for molecular and human genetics at Baylor College of Medicine. He's been recognized and honored by more associations and societies than I can even count. And he is the lead investigator for the BBDC. He's also a New York Yankees fan, but don't let that fool you. He's still an amazing human being. Dr. Brendan Lee.
Hi, everybody. It's great spending this morning or evening or wherever you are with you. It's a great honor to represent an enormous number of clinical investigators, including Dr. Sandhaus and Tosi, who spoke before me, and importantly also the OI Foundation in this partnership that we are now really in the past decade focused on. I love this slide because I think it gives us historical context of how the OI Foundation and the researchers in the field have driven our change in our knowledge and our care of patients with osteogenesis imperfecta. And you know, this is one important metric for those of us in science, which is published, peer-reviewed data that gives us information about osteogenesis imperfecta, the number of papers published each year. And you can see that, you know, there have been important milestones, which at least my perspective, that I think have helped to drive the field forward. The very first, I think, critical one was the discovery in 1985 that type 1 collagen was the major gene when mutated causing OI. Dr. Gloria's work, which was really the best example of the application of bisphosphonates, arguably the first sort of effective pharmacological therapy in osteogenesis imperfecta. The work from our group and Roy Morello discovering new forms of OI, which opened a floodgate of the genetics of OI and studying mechanisms around this disease. And then really continuing The investment of the OI Foundation, first the Link Clinical Research Centers and then the National Institutes of Health, building on the Link Clinical Research Center, the Brittle Bone Disorders Consortium, which I'll talk about and some of the work that has come from it. And this really acceleration of discovery, which we hope to continue to go on for many years, because as you all know, living with OI, there's an enormous amount we still don't know. This is the BBDC, or the Brittle Bones Disorders Consortium, is a partnership of really many of the major investigators and clinical centers focused on OI in North America. You see many of the sites here. I'm not going to go through all of them, covering the country. There is, of course, the critical partnership with the OI Foundation, who is with Tracy Hart, one of the main investigators, and a partnership, therefore, with all of you. And there's a data management center, which helps to coordinate many of the activities. Now, importantly, we could not do this without the support of the National Institutes of Health. And this is one of the few things in our country which I think is still bipartisan, and there's great support for moving science forward. And these are some of the centers that support our Brittle Bones Consortium. There are now over 5 of the centers, which are the institutes that actually support us, including the National Center for Advancing Translational Sciences, the Center for Arthritis and Musculoskeletal Diseases, Dental and Craniofacial, Child Health and Human Development, and most recently, very excitingly, the National Institutes of Mental Health. And of course, the OI Foundation has supported us, and the Children's Brittle Bone Foundation prior to that with the Link Clinical Research Center. One of the most important studies which all the sites participate in is this longitudinal study, which is this natural history study. One of the elements of trying to understand any rare disease is that there are never sufficient patients in any one site to truly have a sufficient sort of experience to identify all the issues related to that disease. And so the core study is to enroll close to 1,000 individuals with OI from over 12 sites, and to follow all aspects of their disease and the progression, their response to therapy, their specific targets in understanding things like vertebral compression fractures in the most common form of OI, OI type 1, the natural history of scoliosis, the craniofacial and dental phenotypes or issues in OI, and impact of pregnancy and lactation on bone health. And then there are many sub-studies that leverage this core study. You heard Dr. Tosi talk about all of our outstanding work on quality of life and quality of life measures. Try to identify biomarkers that tell about severity of disease, imaging at a very high resolution, the craniofacial elements of OI, so that we can understand how we can affect and impact oral health, pregnancy issues, and you heard about Dr. Sandhaus's work on cardiopulmonary outcomes. And then more recently, because exactly of work from here, we've been funded to look at anxiety and pain and other neuropsychological issues related to OI. The sites and the investigators have done great. There are over 900 participants. And thank you to all of you who are part of this study. If you're not, you should join. And you can see their accrual over the years from when we started in 2014-15 period of time. And we've learned a lot. You know, the natural history study has taught us a lot just by seeing patients and collecting in a systematic scientific fashion what we call cross-sectional data. The big deliverable for us now will be longitudinal data, how an individual and a group of individuals evolve over time with regards to their disease. But even on the cross-sectional data, we've learned a lot. We've published, and these are listed here, and they are available to you. You just need to contact the OI Foundation, go to the website, go to our website. We have reported on C-section delivery in individuals with OI that does not decrease, is not associated with fracture rates, whether you do C-section or natural delivery. There have been many reviews about different therapies. We have reported on the effects of bisphosphonate in health outcomes in OI. This increasing focus on oral health, quality of life in children and adolescents with OI, dental and craniofacial features of different types, including OI type 5 and cone technologies like cone beam CT to study the dental malocclusion and the craniofacial issues of severe OI types 3 and 4. Additionally, more studies on OI type 5, the impact of cavities, caries prevention, prevalence, and experience in individuals with OI. So many things which I won't have time to touch on, but hopefully you'll hear about some of them. And as you'll see in more additional talks, both during this meeting and in the future. Focusing, as you heard in the first two talks, on extraskeletal issues and quality of life. Growth, for example. We know growth is impacted in OI, and our experience has been published here. Pulmonary function, Dr. Raggio and Sandhaus's experience. Incorporating your perspective in studying a rare disease, really driven by Dr. Tosi. Mobility, this is very important because mobility impacts our quality of life, and how do we quantify and measure mobility? These are all important, as you'll appreciate, because they get at a very important element that the NIH wants us to focus on, which is clinical trial readiness. Assessing the disease experience, again, in terms of patient-reported outcomes, and Dr. Tosi had mentioned this. So what is new? Those are some of the papers that have come out over the years from your hard work together with us. The past year has been very, very active. Many, many new publications have come out reporting from the study. There was a paper on hearing loss, quantifying and characterizing hearing loss in OI in North America, and I'll touch on this. Some of the tools that can be used to measure quality of life and physical function as it impacts clinical trial readiness. I'll touch on this. Quality of life in both children and adults with these tools. The key pregnancy survey that some of you may have participated in from Dr. Krakow during this study came out and was published just recently this year, emphasizing that there is increased bleeding risk oftentimes with OI women who deliver. Analyzing the tooth phenotype, how dentition is affected at a very detailed level. Reporting elements like rotting and some of the interventions beyond drugs that we use. Malocclusion again, and this is critical because this impacts quality of life for OI patients. And then, as I touched on, longitudinal growth, but now looking at hand films and how the bones in the hand may predict and correlate with this. So again, many, many, many data are coming out, and I expect the rush to continue in the next few years. This is one example of that. And again, this is available to you, but this was work from one of our recent trainees as part of the BBDC, which is a big part of our mission with the OIF to train the next generation of investigators, looking at hearing loss among the different types. And it quantifies the different level of hearing loss, moderate, severe, and among the different types, which helps to also tell us and guide you in thinking about preventive and interventional measures, also the distribution among different ages. This type of data, cross-sectional, but then now we want to see how each individual progresses over time. Another very important element is something called clinical trial readiness. When we test if an intervention, like a new drug works, one of the most important things the FDA wants us to be able to tell is, can we enroll enough patients to actually distinguish whether a drug works? And this is what clinical trial readiness is about. And by working together with you in this study, Chai Murali, another one of our previous trainees, looked at a tool for evaluating physical function and mobility as part of a larger set of tools, and was able to predict how many patients would be needed in different types of trials to detect the difference if a drug was, let's say, 10 or 20 or 30% effective. Sort of what you've heard with all these vaccine studies in COVID, the same idea of how do you actually determine efficacy in a clinical trial. And so this is really important because with this information, we can not just work within the consortium, but with drug companies and other investigators to help power the kinds of trials that they may be interested in. We've really made a big push into the oral health element, recognizing from you how this can impact, being able to chew is an essential element in our quality of life. And in fact, based on that study, Dr. Janice Lee, Deborah Krakow, and Jean-Marc Retrouvé is leading a new study, which we're very excited about, which I'm sure you'll hear from Dr. Retrouvé tomorrow, studying how effective are clear aligners in moving teeth to correct malocclusion. And I think many of you who have severe OI live with this problem, but can we get outcomes like here in H using clear aligners? As you know, your teeth are brittle. You can't use traditional hardware. And so this will be very important in terms of moving this forward. We are very active in trying to develop new drugs. And this is a study that we've now completed, and you've heard of me talking about it, where it's now in review, where we discovered that in bones of not just mice, but in patients with OI, shown in the second and the third rows, there's this increased amount of this protein called phosphosmad2, which is a reflection of how much TGF-beta, a very important control protein in bone, is active. Here you have control bone, which you see very little of this marker. You see tons of it in OI bone. And in fact, by blocking this, by decreasing the amount, we see that especially in OI4 subjects at 1 and 4 milligram doses, we see improvement in bone mass. And this is after a single dose following at 3 and 6 months. And in fact, now we're doing multi-dose testing. Now in severe OI, we don't see the same effect. And this suggests to us that maybe we need to actually change the dosing and maybe go even higher for patients who have more severe OI. This is the basis of hopefully future studies by Sanofi Genzyme, who are partners in this study. So there are other studies which are coming down the pipeline. I had mentioned the new funding from the National Institutes of Mental Health focused on psychosocial needs of individuals with OI across a lifespan. That's led by Dr. Storch. Dr. Sandhaus mentioned their study that has been focused on cardiopulmonary outcomes, and the BBDC is delighted to help support a pilot to expand some of that work. Dr. Krakow received new funding via the BBDC and the National Institute of Arthritis and Musculoskeletal Diseases to study now in depth this bleeding risk, to actually get the records of individuals who've had this issue during pregnancy, to understand what type of bleeding, how much, and eventually hopefully drive interventions in the future. And Dr. Oles and Nichols have been planning additional studies on growth and biomarkers and many, many more. I know that I've touched on a lot of issues, and we appreciate that. And we want to work with the OIF to really go in depth into studying each of these topics and papers. And in fact, OIF has sponsored a new series. You may have heard me introduce this with Cameron Peng, and Dr. Krakow just recently had a discussion on women's health and pregnancy about sort of the data that are coming out and putting it in context of the sort of the work that's been done already in OI, and their upcoming talks on cardiopulmonary study, on the dental study, on mental health. And we hope to really touch on every single paper and project that we've worked together with you in this area. I would also touch on that there's many, many exciting studies from OI research outside of the BBDC. And that's important to keep in mind. That chart I showed you is not just from the group that works on the BBDC, but many, many of our partners outside of the BBDC. As you know, there is an anti-sclerostin antibody study that's just been completed among many investigators sponsored by Mereo. There's talk of perhaps moving forward on that study with Mereo's partnership with Ultragenyx. Many investigators are discovering new genes that cause increasingly rare forms of OI, and OI is becoming really not just type 1 collagen, which is still the majority of cases, but in fact, many, many more genes. And this is important because those rare cases teach us about how bone can be formed and maintained. There are increasing studies on mouse models that focus on these other rare forms in terms of treatment and how and why they give bone disease. And then, of course, alluded to throughout, systemic manifestations of OI. I think really important topics all coming down the future. And finally, thank you to the OI community because of your interest and your participation. It is with research that we really can transform the field of OI care, and we could not have done it without you. So thank you very much, and I'm happy to take questions with the rest of the panel.
Dr. Lee, thank you very much. Always an amazing presentation. We do have time for questions. So Dr. Sandhaus, Dr. Tosi, Dr. Lee, we'll be coming to you shortly. We have some that are in the chat. We have some that have already been sent in. Dr. Lee, I'm going to go actually right back to you since you're ready to go. On the Freslumab study, what types would benefit from this treatment, and when do you think it's going to be available publicly?
So, with the Frizzo study, we've studied only adults. We've studied severe forms of OI, primarily OIs type 4 and 3 and collagen-related forms. And our early result, as I just sort of touched on, suggests that OI type 4 subjects patients that we studied had a pretty robust response with a single dose, and even at 3 and 6 months. As I mentioned, the severe forms OI3, and we studied one patient with OI8, did not respond in the same way. And so our next step is to study the repeated dosing, and that's happening. Unfortunately, because of the whole COVID issue, we're not going to be able to necessarily complete all the patients there because of the shelf life of the drug. But I'm very hopeful that Sanofi Genzyme, which is the drug company that makes fresolumumab and who studies it, will then really move forward with a very large multi-center study to really take this forward ultimately to FDA approval. Now, they've not committed to this, but I'm hopeful that because of the data that we've generated, which I think are very encouraging, that they would in fact take this on. So I don't have a definitive date, but I do think we've generated the key first steps that will hopefully interest them and perhaps other companies. I know there are other companies interested in targeting TGF-beta, and whether it's with Frizzo and others, maybe there will be some other coming down the pipeline. But I am enthusiastic as this may be a very effective treatment for severe OI in adults.
While we're on that subject for bisphosphonates, we had another question regarding types. Does it work better for, say, type 1 versus type 3, where you're looking at quantity of collagen versus quality of collagen?
So I think there's no question from a lot of work from Dr. Gloria and Dr. Rausch and many others that bisphosphonates are really the standard of care and very effective in children with OI, and certainly with severe forms of OI in children. So I think that with OI type 1, it's not necessarily used across the board, but I think in many of the studies, OI type 1 children have been included, and it also works effectively in them. This idea of quantity versus quality, as many of you know, with OI, severe OI, the quality of collagen is affected more, and while with OI type 1, it's more the quantity. Certainly, one of the way bisphosphonates work is to make more collagen, and one would imagine that with something like OI type 1, you could make more normal collagen because you're preventing the resorption or the taking away of that bone and collagen. But what we don't know is, do we really need bisphosphonates in all patients with OI type 1? That's something, again, that hopefully the study will show and give us information on. In adults, bisphosphonates in general have been studied. They've been rarer studies, and they've been all more smaller experiences. And in general, it also increases bone mass. What none of the studies have really definitively shown is that bisphosphonates can change fracture rate. And this could be because of the sizes of the studies. It could be because of the different types can respond differently, which is, again, one of the reasons why we have to focus on clinical trial readiness. And there have been reports that perhaps in some adults, they don't respond as well. And that may not be unreasonable because of the way that bisphosphonates work, children make a lot more bone. And so as you block bone resorption, children get a better benefit. Unfortunately, for all of us adults, our bones are turning off as we age. And so you can imagine bisphosphonates won't necessarily have the same effect as in a child.
Thank you, sir. Dr. Sandhaus, I'm going to go back to you because some folks who may not have seen this in the chat section there, your answer. Regarding lung issues and results, are they specific to a certain type, especially any non-collagen mutations?
Right. So we made an effort in this pilot study to have a broad range of OI types. And so that allowed us to have a wide variety, for instance, of scoliosis severities and stature, levels and things like that. So we didn't enroll enough. We haven't enrolled enough people yet to make broad, generalizations about how one particular type acts as opposed to another. But we did see very similar changes, especially the key change of bronchial wall thickening that were across all types of OI. So remember, this is a pilot study, and we may eventually want to expand it to look at very specific questions like, does a particular type have a particular lung abnormality, based on the logic of the type of abnormality associated with the particular type. But right now we're looking broadly, and so I can't really make any specific comments about ways in which the types differ from each other than that the more severe forms of OI have worse lung function. Excellent.
If folks wanted to take part in this study, regardless of type, what's the best way to do that?
Well, right now, the enrolling site is in New York City. Obviously, we've been, and we're hoping to expand that to sites around the country. We've very much been limited in our enrollment to people who can travel to the labs in New York City. But as COVID, with our fingers crossed, as COVID fades more and travel restrictions get opened up to the point that an OI patient would be comfortable traveling to a study site, we'll try to get more people from other locations. But if you have an interest, please call Kathy Raggio's lab at Hospital for Special Surgery. I don't have the number to call at the top of my head, but I can start looking for it and put it in the chat when I get a chance.
Excellent. We appreciate that. Dr. Tosi, Dr. Lee, we have questions about adult OI. What's the latest in adult OI research, and also what can be done for senior citizens with OI?
Very tough question. I'm not sure we have a latest. I think we have, other than Dr. Sandhaus, Dr. Raggio's phenomenal work. I think it's a different issue that we're trying to delineate what is the same and what is different in adults versus kiddos. And at the risk of tooting my own horn, we did do the ANI study, Adult Natural History Initiative, that was published in 2015. It's free on PubMed, and it's easy to find because I'm the first author. But what was new and different about that study, besides the fact that I broke every rule and asked far too many questions, is that it delineated far more extensively the variety of issues that adults with OI have. And you'll see that we show the stats. When are patients with OI on average like everybody else in America, and when are they different? And there's a broad range of disorders that are different. And so as we do get more interest in patient-centered outcomes research, it is clearly part of my dream to start really documenting what's going on with our adult community so that we know better what to focus on.
Yeah, I think Dr. Tosi is exactly correct. The first step is, in fact, the kind of work that she's led to identify the problems by talking with you. And I think that from there, then we see an enormous number of targets that we have to then get better information on, which is what the BBDC strives to do with you. And then to model that in animals, because obviously to understand mechanism, to fix disease, you need to understand mechanism. That's where the preclinical animal modeling comes in. I think that in addition to the cardiopulmonary issues, I think there are still long-term issues of what, as was in more senior and mature individuals, of what's the status of bone and how that is affected by treatment. I actually believe that OI is a model of accelerated aging. I think many of the things that we see are like that. So, I think we'll need to address hearing loss, especially in older individuals, and all of those are important topics. And so I think that we will just need to work together with you and systematically. And this is part of why we've also been so lucky to be supported by so many institutes of the NIH. We're actually quite proud of that. And part of the reason is because, as you have all taught us, OI is a true systemic heritable disorder of connective tissue, and it's not just about bones. And I think studying adults as life progresses will be very important in that.
Thank you both. Dr. Tosi, I'm going to actually go back to you because this question comes from Dean. And Dean, we're actually pursuing a study and funding on this. What is the best standard of treatment once a child ages out of pediatric care and is a young adult in their early 20s? He's asking specific to type 1, but in general, all types.
Well, I don't think we've defined that, but I certainly have my prejudices. And certainly whether it's making sure that kids don't start smoking, as we're going back to a lot of pressure on that the kids keep exercising. At our own institution, we are doing bone density studies. Some of these kids have been on bisphosphonates, some have not. And we are eager to see how their bone density is doing across time. We do not yet have standards on who needs a booster dose of bisphosphonates. These are, I think you can see the list of questions goes on and on and on. We have a huge problem once the kids leave us or leave home and go off to college. They stop taking their vitamin D and they aren't consuming enough calcium. These are basic things that are more critical, I would argue, for the individual with OI than they are for everyone else, because maintaining that bone and muscle strength is so critical to everything else we have. But right now, within the OI registry, if we're lax in our definitions, we have 5 centers who say they see adults. That's not good. And so over the next year or two, Tracy and I will be talking to you about some efforts we have to try to change that picture. And one of the things is I like to call it a sort of ecumenical effort. Rare disease is rare disease. And there aren't that many OI centers, and there surely aren't going to be that many adult OI centers. But potentially over time, we will have bone health centers where our community will feel comfortable and will have access to expert care. And so we are really working with the other members of the Rare Bone Disease Alliance to try to start to look at what that might look like, so that we can ensure that no one is too far away from someone who will give them appropriate, not off the cuff, but appropriate guidance and care.
Thank you, Dr. Tosi. I know that question has actually come up a number of times.
Yeah.
Living in San Francisco and not having access other than LA and a few other places, we are actively working on that at the OIF, at the board level. So it's a slow process, but it is a process. And Dr. Tosi and several others are taking the lead on that. So we really do appreciate that. I'm going to open this one up to all 3 of you. We have a question from Irene regarding Osteopan tablet taken by mouth. What do you think about it? Some researchers say that it's more effective than calcium carbonate. Is this true? Is it helpful for OI in adults? And are there any studies either that have been done or will be done on this?
I'm embarrassed. I've never heard of it.
I'm sorry, I didn't hear what was the
Osteopan?
Osteopan?
Osteopan, osine hydroxyapatite.
Oh, it's is it okay? You know, I think when you think about nutritional supplements in general, where you're trying to take components of the matrix, and you know, examples of this could be this, which has hydroxyapatite, it sounds like, or it could be glucosamine when people who take it because of cartilage. I think that without really controlled studies, it's very difficult to know whether it's actually efficacious. And one element is it's always challenging to understand how matrix component can get to its target through the gut. And that's not to say that it's with these types of supplements, it can't be an effect, because we don't know everything. And sometimes these supplements, including matrix supplements, can stimulate pathways. That's not that it's working directly and getting to the tissue, but it's stimulating responses systemically that may have an effect. So I wouldn't necessarily just eliminate them, but I think with any nutritional supplement, you have to appreciate that there are really very few controlled trials, if any, that they're not often regulated in the same way. So the content can change over time. And, one should, obviously be careful about those issues. That's my general feeling, not specifically about that, but just for nutritional supplements. I don't know if others have comments.
All right. A general question: what new treatments are out there or on the horizon for adults with OI?
I think we've touched on some of them. I think when you think about the drug treatments, if it's related to drug treatments, or obviously the important nutritional elements that Dr. Tosi touched on, vitamin D and calcium, that's a baseline. That's the fuel for the bone. But then obviously with bisphosphonates are available, Forteo, which is a bone building agent. We have shown in clinical trials to work in mild OI, maybe not as well in severe OI. The anti-sclerostin study, which again, in adults seems to, based on what has been released in press releases, seems to have a positive effect. But again, definitive efficacy studies haven't been done. Same with the frizolumab anti-TGF beta therapy. So these are certainly things which are all either already available or in the pipeline. And I think there's increasing interest from other companies. One of the important challenges will be working with the FDA to develop endpoints, as we call them. What can be measured that's reasonable. And that's really a challenge. If we cannot get an agreement on that, there will be less investment in this space, because companies and researchers won't do a trial if they don't feel like they can get that answer. So this is why I underscored that idea of clinical trial readiness.
We actually have a follow-up on that from Courtney. Are the TGF beta studies ready for pediatric trials?
No, not at this point. I think we have to complete the studies in adults first. And, I think that most drug development will start with adults and try to demonstrate efficacy in adults, and then from there move on to children. So certainly at this point, it's focused primarily on adults.
Got it. Thank you very much. And also one quick follow-up on that. Where do we stand on stem cell research?
So I think this, stem cells have enormous potential because when we think about any degenerative disease, whether it's bone, the brain, cartilage, once degeneration has occurred, you have to replace it. And we all live with the fact that, again, our bone mass decreases but beyond our 20s and 30s. And so at some point, regeneration will be important beyond, delaying the degeneration. And stem cells are a great opportunity for that. I would say that, especially with OI, it's challenging because, again, you're not targeting one organ in one place, like the liver or the eye or the kidney. You're targeting the bone, which is everywhere. And then, of course, collagen is in tendons and ligaments and the lung and so forth. And so it's especially challenging. It's not to say that it might not have a benefit, but certainly at this point, I see stem cells as, especially for OI, being a very high bar. And the other reason, in addition to the fact that there's so much neighborhood and territory to cover in OI in the body with stem cells work best when you make space for them. It's kind of like moving into a neighborhood. You have to have some open houses to live in. And in fact, this is why when we do bone marrow transplantation, which is stem cell, the first original stem cell therapy, you have to do ablation to make space. It's very hard to do that in the skeleton. So For those reasons, I think we have to invest, we have to move forward. You don't give up on any therapy, especially one that can address the regenerative issue, but it is certainly much more challenging than perhaps some of the other diseases.
There are other treatments out there that are being mentioned that are injection therapies. Have you heard of any success with prolotherapy or platelet-rich plasma treatment for OI patients with deteriorating joints or spine?
So I know a lot about platelet-rich plasma infusions. We've actually studied it in the context of osteoarthritis and published papers on it. You can look those up. Platelet-rich plasma has been used primarily for joint diseases. It has been used for some tendon type diseases. And I think that the data both in models and in humans suggests that there can be some beneficial effects, especially with relates to pain. What I would say is that that one has to be careful, because even in the world of clinical platelet-rich plasma therapy, there's no such thing as one platelet-rich plasma. The types of preparations vary tremendously from provider to provider, from kit to kit, and you just need to be alert to that. They're all different types of formulations, and so, you know, I think being an educated consumer is very important if you're going to pursue that. I think there's no question there can be positive effects, but they're generally short-term, at least in the studies that have been done. There's nothing I know of with regards to bone. It's primarily more for joint and, you know, tendon applications. I don't know, Laura, if you have anything to add on the PRP issue. Obviously, often.
No, that it's, you know, and the cash outlays are huge for patients.
Yes, it's not covered generally by insurance.
Right, so it's not realistic.
Yeah, thank you, Dr. Tosi. I'm going to actually go right back to you. There's a question on the chat, and we do have information posted on OIF.org, but are there any plans, programs to help educate NICUs and other childbirth centers about the care and understanding of OI infants? And if you're going into, if you know your child may have OI before childbirth, what should you be prepared to tell your caregiver going in?
So the OI Foundation has just recently published, and I'm going to get the name wrong, an extraordinary publication on the newly diagnosed kiddo. I would strongly urge, I believe we have now opened it up to everyone, that anybody who's interested in this topic, look at the presentation by Dr. Bober at our most recent town hall meeting. And I want to come back to something I mentioned in my earlier talk, which is that one of the findings in our PCOR work was that we really weren't engaging all of the OI clinical centers. And so if we are going to hope to have high quality care, good access to care, everywhere, we need to be sure we're reaching out. And we've initiated town hall meetings. We've now had 2 of them. We were thrilled with the attendance and the participation that came with that attendance. And again, we're doing COVID learning all the time. So we didn't really record it the first time. And the second time we said, my golly, we can't waste these wonderful presentations. And that should be up on the OI Foundation website. And his talk is breathtaking, is the only way I can put it. It's insightful, articulate, etc. And we're eager to share it with as many folks as possible. If you were aware of a NICU, et cetera, that was interested, frankly, you know, it makes for a really good session program in and of itself. And I'm 97% sure, Michael, are you on the call? That it can be downloaded as a separate piece. I can't recommend it enough. And again, the handout that was developed is quite extraordinary as well in terms of its comprehensive nature and its readability.
It is, and it is posted. I can definitely speak for Michael. If everybody wants to take a look in the chat, the links are posted there. You can download them. You can give them to your doctor. This is a long time in the making, and they are fantastic. All right, one last question. And before we depart, we have to have one COVID question. Current conditions, Dr. Sandhaus, start with you. Travel, airlines, airports, hotels, what's your general take right now?
Well, you know, it really depends on the status of the individual. Number one, are they vaccinated, the potential traveler? Number two, do they have underlying issues that make them more likely to get severe disease if they were to get infected? Because there's still the possibility of infection out there, especially if you're traveling unvaccinated, even if you use things like masks and social distancing, which are very difficult to do in terms of social distancing when you're sitting 3 inches from the person in the next seat on an airplane. I have to say, I've done my first airline travel after 15 months of not traveling. When usually I was traveling at least half of every month. And I found it to be exciting, to say the least. I even had a false start on my airplane, which left the gate for the taxiway and turned back because there was one passenger that refused to wear their mask, and security got on and took them off, and we headed out again. So part of the issue, at least in the United States, is that there are still deniers of risk. And it really depends on a risk-benefit analysis of how important a trip is with how safe you feel in terms of protecting yourself from COVID. The more people that get vaccinated, the more safe travel becomes, and the more safe congregating becomes. And, you know, we're just waiting for the next peak around the corner. I don't want to be a pessimist, but I have to be a realist in terms of how to protect my patients. So for the moment, we're in a somewhat of a lull, depending on what geographic area you're in. And so the final thing I'd say is know the risks in your particular location and in the location you're heading towards.
Beautiful. Thank you very much. And before we close out, Melissa's going to present an interpretation survey, some information, more information for you. We'll get to that in 1 second, since we are just about out of time here. It's hard to believe that this is the second year of these virtual conferences. I want to thank everybody for taking part of this. Next year, we'll consult with Dr. Sandhaus and everyone else in Orlando. Our goal is to do a hybrid in-person and virtual event. Obviously, we'll see how that goes, and we'll take it as it comes. We'll be consulting with our medical advisory council on what's possible, so stay tuned. I want to thank all of our sponsors again one more time: Ultragenics, Kennedy Krieger, Shriners, Children's of Omaha, Nemours DuPont, Pega Medical, as well as all the medical professionals who appear today and will be joining you throughout the weekend. Coming up next, the Adult Health Panel at 2 o'clock, sponsored by Kennedy Krieger. Pediatric Health Panel, 2 o'clock also, sponsored by Shriners Montreal. Don't forget, we've got the Kids Social Zoom at 2 o'clock today, 2 to 6:30 p.m. Parents Meet and Greet from 4:30 to 6:30. The Adult Social Hour, 7:30 to 9:30. Get your virtual wine tasting tickets now at oif.org/adult social hour. All these times are Eastern. So with that, Melissa, I'm going to turn it back over to you to clean up anything I messed up over the past hour. And thank you to everyone for joining us.
Thank you so much, Cameron, and thank you to Dr. Sandhaus, Dr. Lee, and Dr. Tosi. You can see on your screen right now, we have a poll. We're very excited this year to offer our live interpretation services in Spanish and French, and we would just love to know what language you listened to today. So please take a moment to fill out the poll as you're exiting. We are moving right along. We have our adult health panel, our pediatric health panel, and our children's Zoom starting in about 15 minutes. So we hope we'll see everyone at those sessions. I believe the links have all been posted in the chats. So see you all soon. Thank you.